Good morning. I am here today with two special guests. This is Joe Alch. I'm an RN with Acappella Podcast. We have Brian Harmon. He is a physical therapist, MBA. Great information in the industry right now. And then Brian Levy, I want to welcome you back. Brian is the community liaison for Manchester Place and Cambridge Caregivers. Great team. And we are talking today about the reality of the ratio in communities. Yeah. So we're going to start about a story that has been on the news, national news, talking about isolation in nursing homes and communities and not being able to see their loved one. So this woman was not able to see her husband for 113 days and just wanted a reason to get inside. Her husband needed touch and support, and he was declining. She saw the weight loss, and the community actually offered her a part-time job as a dishwasher. And it's so amazing. So she took the job gladly and was able to reconnect and see her husband a few days a week for a few hours a day. She had to do her chores first, but then she was able to visit with her husband. That was so needed.
Yeah. Joe, that story completely reminds me of Mrs. Doubtfire when Robin Williams' character dressed up as the housekeeper in order to see his kids. It's exactly what that lady did, and good for her.
Wow, I know. It's interesting what you can do, if you just become resourced. If there's a will, there's a way.
The things you will do to see your loved ones.
I know. So we're talking about ratio, and leads us to a good conversation. I have a heart for seniors. I know you guys do too. I believe the best care is one-on-one care. It still needs that supervision. Brian, you're in Medicare, so you do have a different role than I do. Right. And Brian Levy, you have not only residential care homes, but you also do what I do in private duty. And we all three have good reputations in the community as really wanting the best for our patients and for each other and their families. So we're talking about staffing ratios in communities. And I am seeing this with the COVID crisis. It is a pandemic. We just talked about before the show aired, we really thought we're going to have a lull come June, July. Everything is just going to slow down and we can get back to some new normalcy. Well, that hasn't happened. And we know we're about to start school. September is when the flu season starts. October is when the rise in pneumonias, bronchitis, strep throat. Kids are in school bringing stuff home. So we got to talk about what is going on as far as realistic ratios with COVID right now. So we're going to talk first about when you've got somebody calling and needing care for their mother and they don't know what to do and they have an option. Joe, I just got a call from the doctor. He told me that my mom has got to move to an assisted living. She can no longer take care of herself. So what do I need to ask? And so my number one thing I'll say is never look at the building. The care is what's important. We can all live in a nice house, but you don't know what's on the inside. And, I share this on my podcast. My very favorite patient I ever had lived in the projects with bars on her walls. I learned more from her and was treated so graciously and respectfully than I have been in some of the biggest homes in America, right in Dallas, Texas. Right. So anyway, you just learn a lot with people. Our product is people. The community's product is people. So let's talk about ratio in assisted living. When you guys go to an assisted living, what
we have strong feelings about this.
And what is the reality? We're talking reality. We're not talking, we're going to be politically correct for these communities. Yeah. Let's just openly discuss.
A lot of it, I don't know the rules and regulations and laws about disclosing what your ratios are, quite frankly. I know they're not accurate. When someone's telling you that they're 15 to 1 or 20 to 1 or even 4 to 1, how do you know that that's really the truth? But the proof's in the pudding, I guess. When you walk around the halls and you see that mom's in room 14 and there's one nurse roaming around, where's the other? Is this what was really happening?
And I don't know if you guys know. Okay, this is what I've been told, and I looked for assisted livings for my father, and I have been told that that ratio includes the dishwasher, it includes the security,
The maintenance
it
guy.
includes
Yeah.
maintenance, but they're not going to share that. So when you're asking for the ratio at an assisted living, how does the adult child making that decision? How do they ask that question?
I don't even know that. I mean, you can ask the question, but I think probably one of the best ways to go and actually get the information is to go tour at different times in the day and see, are there caregivers actively roaming the halls? Because I know in some of the bigger buildings I've worked with, it's like they're playing Marco Polo. You're yelling out Marco, looking for anybody else around the community to come out of the rooms, and so that. And we've talked before, as the level of acuity or the level of need goes up, there's going to be a need for more caregiver assistance. And so if you're more independent, some of those places where there's a 20-to-1 ratio or whatever, they're perfectly fine. But as you start to have more and more needs, more and more help, that's when the caregiver ratios really start to become a lot more important.
That's the key, is you got to know the questions to ask. When you're touring a building and it's beautiful and, happy hours at 4,
Right.
bingo's on Tuesday. This is beautiful. They have the
Here's
fish
the movie
tank.
theater.
Oh, absolutely. Yeah.
Yeah.
It's, all the bells and whistles. But what are your care needs?
Yeah.
And oftentimes families don't know to ask about those things. So know the questions to ask, not just ratios, but daytime ratios compared to nighttime ratios. Oftentimes care homes will have, 2 people on staff, but at 10 p.m. it goes down to 1 on staff and they're asleep. So ask the questions and then keep asking.
So wait a second, the one on staff, it is okay then for them to sleep?
They're very, again, licensed, unlicensed, 3-person, 6-person, 16-person. I mean, care homes, Manchester Care Homes, we're licensed as type B small. So we have 8 residents and 2 full-time staff people on duty 24/7. So
are they allowed to sleep?
No, first of all, there's so much to do.
Yeah.
At night, there's cleaning, there's meal prep, there's, we check on our residents every couple of hours. We turn residents, we change residents. I mean, it's a full-time operation. So I don't know how other facilities do it with regards to nighttime staff, but ours are working.
I took care of this patient. I got to the community, did my nurse-to-nurse report with the nurse on the floor. She told me to come get her. I could not keep the medicine for the patient in the room. Patient was having pain. So about 11 o'clock, I went to find the nurse, no nurse. 12 o'clock, no nurse. I scoured the building, no one. There were also 2 caregivers that were on staff at night. So there was a nurse, 2 caregivers. Never once did I find anybody. All night long, my patient had pain. So in the morning, when the director of nursing showed up, I said, I just wanted you to know what a hard night I had for your patient. I couldn't find any staff. And what is the procedure? Are they allowed to sleep or do they go to a room? Long story short of it, I was kicked out of the building, never allowed in the building again. And so that is...
You expose them.
Yes. And so, you've got to be politically correct. We do. And what's sad too is I see, the old expression, squeaky wheel gets the grease. Well, if you complain too much,
Right.
It's the opposite for your loved one.
Right.
You know,
and people are very apprehensive to complain or raise a red flag or even ask questions.
Right.
We had a woman move into our care home a couple of years ago she was 98. She was in great shape. She could walk without a walker. Got up to go to the bathroom at, maybe 11 o'clock. Well, she fell, couldn't reach the call button. They found her the next morning in the bathroom on the floor. And, the family, of course, they're raising holy heck. And they asked, what happened? How did this happen? And the nurse fell on the sword and said, I was the only one on duty last night. And by the time I made the rounds of all 33 rooms to get to, I found your mother.
But how are communities allowed to have only one person?
Dollars and cents.
I know.
It all comes down to dollars and cents. They just can't afford when you look at your P&L and do we have money for another staff person? Yeah.
I think it's also a flaw. It's a flaw. There's the AL industry needs to be transforming or transitioning. You know, back in the 80s and 90s when these things first started, it was kind of about hospitality only, right? We've got these nice buildings, we've got these great chandeliers, we've got all these activities and these amenities. And now what you're finding is that like 90% of the reason why they move into assisted living in the first place is because there's a declining in health or decline in function. Yet we're still selling a hospitality-based model. And that, I think, is the biggest flaw. I think we need to transition from the hospitality to one where, yes, hospitality is important because we want quality of life, we want engagement, we want all of those things. But the healthcare part of it is being neglected, and in part because of cost, or in part because it's just not their core competency. And I think as we look into the future, and I'm hopeful that COVID-19 is actually going to help further this conversation faster, we're going to start seeing a lot more community engagement on the healthcare side of it as well. Now, you can insource it and bring on your own staff, or you can find great partners outside in the community and create collaboration with them to help make sure that you're meeting the actual needs of the people who are moving in there and why they actually moved there in the first place.
The other thing that Brian and I talk about all the time is when you're in an IL or even in an AL, there's that no man's land where mom and dad are applicable for a larger facility with happy hours and movie theaters like we talk about. But then 6 months later, you need to look down the road because you don't want to move them back to back. So you put them in this facility, they go to the movie theater once, mom quits drinking, happy hour is not fun, and now they're declining. Yeah. So you pack them up and you move them again.
I know.
It's no man's land.
No.
That's tough.
So really think further down the road. Think about the care and what do they need now and what are they going to need.
Right.
Well, and I know I met with a family the other day, couple, they're 92 and 91, wife fell, had surgery. Anyway, they don't have advanced directives. They have 5 adult children. They do the full code and they are calling the shots. The adults, they are not going to allow the kids to participate. Yep. So sometimes those families in situations like that, and I just recommend call your doctor. Let adult children call the doctor and say, "Hey, we're at a crossroad here, and mom and dad need more help. And how can we work together?" And that leads to they might say, "You know what? Why don't you have a service through Medicare come out and provide nursing once a week for your mom or dad or physical therapy?" So let's talk about, I know we're just so excited about all this. So let's talk about Medicare and what is Medicare providing right now for a patient during the COVID crisis? What are a realistic expectation for what Medicare can do for someone in the home?
So with coronavirus now, what you're finding is there's a bigger focus on care delivered in the home. So this is a huge opportunity for not just the industry I work in, but also for the family members and the patients themselves to be exposed to a lot less risk and having care professionals come, whether it's physicians or therapists or nurses coming to their home and reducing the risk of exposure by having to go out. And you're seeing, even now, you're starting to see some of the hospitals doing a skilled nursing facility diversion where they don't really want to put them in a building where there's potential exposure. They're actually discharging them straight to home. And so we can do a lot of things in the home, from the physician side to nursing, helping manage medicational issues or chronic illnesses, from the therapy component, working on things like the functional component of chronic illnesses where, it's maybe harder to get up and down. There's probably some fall risks. So we go in and look at the environment, modify that. What kind of equipment do we need to have? Train caregivers, train family members, those kind of things. But also we want to make sure that we're looking out for their kind of the quality of life things too, and making sure that we're actively getting them involved in activities that they enjoy. Because if you miss that component and they stop doing things that they like, you're going to quickly find that the medical side and the functional side will both start to decline as well.
Okay, so I got a call yesterday, in fact. Patient fell, needs wound care 7 days a week, but wants Medicare to pay for it. She called me thinking we were a Medicare agency, and we're not. We're strictly private pay. And so I recommended you, Brian, your company, and I just said, you need to talk to Medicare. They will go out and evaluate and determine what visits will be paid for. Yeah. And we will fill in the rest. Yeah. So that's kind of how we handle that. And I'm not an expert on Medicare. I don't want to be. Yeah. But realistically, let's say patient has a feeding tube placed and maybe had a stroke. Just around the about, just if you had to you could visualize this little gentleman, 92 at home, how much services would you say somebody in that needing to learn to walk again, difficulty swallowing, needing training on the G2, what would you think would be a good path for that patient?
So there's quite a bit of misinformation out there with regard to this. Medicare does not actually put any caps on visits. All they say is it needs to be infrequent and short in duration. So you could see somebody every day if you wanted to, or you could see somebody once a week or once a month. So they don't really, Medicare itself just provides the guidelines on we're an insurance company, we're going to pay for this, and this is how much we'll pay you for. It's really up to the individual agencies and the clinicians working with those family members and the patients to determine what's the most appropriate course of action. How many therapy visits, how many nursing visits, those kind of things. How often do we need to be seeing them, and for how long? There's not really an arbitrary cap. And I've seen, because I know people, I've seen some of the internal documents flying around where they've just put an arbitrary cap on. You're not going to see a patient for therapy more than 8 visits, or more than 4, or more than 12. And Medicare hasn't really ever come out and said anything like that. There has been some changes for 2020. There's a new thing called PDGM, which is probably the biggest, not probably, it is the biggest change in home health regulations and reimbursement in like the last 20 years. And so the incentives to over-provide physical therapy or occupational therapy or speech therapy have gone away. There's still the client needs, though, that if they need a certain amount of therapy, we should be providing that. But it's all really on an individualized basis.
So let's talk about this. And Brian, I know you're such an ethical guy in what you do. I'm the same way. I put my heart into what I do, and sometimes it bites me in the behind.
Yeah.
But I do have that philosophy. The customer is right. I want the best for this customer. It's kind of like the miracle on 34th Street when Santa sends the kid to another store to get the toy he wants.
Yeah.
If we can't help and you can't help, let's find the right situation.
That's right.
So, and I've seen Medicare agencies that don't have that approach. They just go out and do their nurse visit and yada yada. And then OT comes out and do their visits, yada yada. Nobody's getting any training. Nobody is getting consistency. The family's up in arms. I don't really understand what they're doing.
Yeah.
There's no communication. So what is an expectation from an adult child on how is that communicated to the adult child? HIPAA approval, of course, so that everybody's on the same page and we know the goal.
So sadly, I will say this doesn't happen frequently enough. But the expectation should be that the care professionals, whether they're physicians, nurses, therapists, whatever, or private duty, there should be active collaboration and communication with the family members or interested parties. Again, concerning HIPAA. And one of the things that, Brian and I work a ton together, because what we found, to your point, is there are times where the long-term trajectory of this particular client of ours is that they're going to need other humans in the house, right? And so we work really closely with private duty caregivers to bring them in. And honestly, that's where we do a lot of the training for too, right? Because the family members, especially spouses, right? We see a lot of cases where, we have a lovely wife who's taking care of her husband of, 60 years or whatever. And we're very active with the wife to explain, we've got to build in time for you to have respite. Like you need a break. And they all say the same thing. It's like, no, I love my husband. We've been married for 60 years. Like we dated in high school, all these things. And she's like, I feel like there's an obligation for me as his wife to be his primary caregiver. And I'm like, I love that. But our experience has shown that you're going to decline faster than he will. And so we're really active early on to get private duty involved or other family members involved to make sure that we're reducing some of that burden on them too.
Continuity of care is so important that when we team up and we work together on a case, Brian goes in and we try to overlap at least on the first couple of visits so our staff knows exactly what they're doing and we can continue with exactly how they do it when they're not there.
Well, and that's why it's called an individualized care plan. And we do the same thing. Like if there's physical therapy, let's make sure if you only want 4 hours a day, let's make sure on one of the days we're there when physical therapy is there. So we know what exercises need to be done. We know what is the best diet plan right now, or OT, the swallowing problems. Well, what is the best thing to feed? And we want to make sure they're sitting up, or all those things that we work as a team, because it is a goal. We want people to stay independent, and the goal of the home client is that as well.
That's right.
To stay. So we're getting back to the ratio. I love the Medicare services. I think it's a wonderful service. The story on the block is it doesn't go long enough, and families get mad that, they said they'd be here for 8 months until dad got well, and he is not well. And people confuse that goal, that people confuse when you've reached the max of what you can do. And it's a tough place to be in because they need care. Maybe not occupational therapy anymore, or maybe they're not going to swallow like they did as a healthy person. So what do you do in that case? Tell me about that conversation.
So there's a lot to unpack there. It's probably a time for another show because so we'll sidetrack real quick. There's an industry out there known as consulting for home health. And it's really a fear industry. It's, you've built this company, and the boogeyman, Medicare and OIG, are going to come after you. And so we're going to give you all these little rules, or our interpretations of the rules. And so a lot of times as that gets passed down and you work with a bunch of different consultants, now you've got stacks and stacks of new laws or rules that actually don't exist. And so a lot of times when we hear family members complaining that, hey, the home health discharged me too early, it's not because the therapist or the nurse wanted to discharge or didn't see a point in continuing. It's because somebody somewhere along the line said, oh no, when you reach this point, this is when you have to discharge. Now, there is a point where Medicare does say it's time to discharge. It's not as early as what most people interpret. But when we get to that point, that's when you have to have other people, usually other humans in the home, to help transition to, okay, the long-term plan is this. But Medicare is actually really good about, there's a maintenance program for certain qualifying individuals where you can actually stay out for a lot longer to help them with that. There's some regulations you got to pay attention to with that, but yes, and
there's the palliative care programs.
Yes.
And I know Medicare is working on that. I know VNA here is doing a pilot program for them, and I've talked to them, and I think that's a great program. You have to have certain diagnoses to qualify. Not everybody can go on palliative care and get home care. But it's that generation. It's just so hard. Do we move to a facility or a community? Do we stay home? Do we go to a group home? So it's just a lot to talk about. Okay, so let's talk about memory units 2 and ratio. Does Medicare first go to memory units? Are they situations where you can improve on their quality of life?
Absolutely. Yeah. So this is like one of the big myths out there, even within the therapy community. So I used to work for a research company. Before I did, my understanding of our clinical practice was if there wasn't enough cognitive ability for you to learn, whether consciously or subconsciously, because you can learn movement patterns that don't require you to actually think through it. But if I didn't see that there was an ability for you to grasp what we were doing, then it was usually like an evaluation only. Now, after 20 years of being in practice and a lot more research, you realize that that's actually not the case. There's actually quite a bit that you can do on for a memory care resident. So I'll give you an example. Probably the biggest one the one that made the biggest impact for me was several years ago. I was working in home health in Florida, and I had this little old lady. She was like 92 years old, maybe 80 pounds soaking wet, and she had advanced Alzheimer's. So she was living in a residential care home. But she was, because of how loosey she was almost a 2-person transfer for everything, from the wheelchair to the commode, from the wheelchair to the bed. It was pretty bad. And so they, I guess as a just a trial, let's send therapy out there and let's see what we can do. Well, through using some movement strategies with her, we actually got her to where she was a minimal assist in transfers. It was a remarkable, it was within like 30 days. So it made a huge improvement. Now, I will tell you, I know better now not to go that far, because then the issue is if she's a very minimal assist, guess what she's trying to do now?
She's doing it by herself.
Right. So I by making her more independent, I actually made her less safe. So now I balance that out. Yeah, but there's a lot in a lot of stuff that we do within memory care is it's not, yes, it's client focused, but it's also about the caregivers, right? Because a lot of times like the caregivers aren't really sure how to do the transfers appropriately. So we did training videos with Brian a few weeks ago, right? So like the setup is really important. It's a key for making sure that the transfer is safe, not just for the individual resident, but also for the caregiver. And so we invest a lot of time on the caregiver side too, because that's ultimately who's responsible or in charge of caring for this particular person.
Well, and we had a patient that was in a memory unit and they weren't going to move. The community allowed the patient to stay, but she needed a Hoyer to be lifted. She was really overweight. And so our caregivers did not know how to move her in the Hoyer without hurting her.
Yeah.
And so the family got very frustrated with us because they were like, well, don't they know how to use a Hoyer?
No.
They don't.
Right.
And every individual is different.
That's right.
That's why it's so important. Just because I'm a nurse and I know how to use a stethoscope doesn't mean I apply that exactly to every single patient. Everybody's different. So
we're asking caregivers, to figure out how to do the most appropriate transfer for an individual client. Like this is where therapy comes in really handy for assisted living communities, for memory care facilities, because the caregiver training is really a huge thing. So I'm looking at it through the lens of biomechanics, neuromuscular ability, all these kind of things, and figuring out what's the best approach. Are the devices that we're using the most appropriate ones? Are the levels of the chairs or the beds? Is the mattress the right type of mattress? Is it too small, too tall, too firm, too soft? Like all these things that I'm looking at, I can't expect a CNA or a caregiver to go through all that mental checklist on what are the things that are going to make this transfer the best.
But you can train them.
But you can train them. This is where therapy coming in and doing, even a few weeks of training with caregivers can make the world of a difference for the caregivers themselves, because they're stressed, right? If it's a transfer that I'm dreading to go do every day, I'm probably a little bit slower going over there, right? Or I'm going to have to pull a second caregiver in with me to do this. That's a lot of burden on them too.
Well, especially when it's just it's a Hoyer lift with one person.
Yeah.
It can happen.
It's hard.
We have Hoyer lifts in all of our care homes. And let me tell you, it's a 2-person operation.
Yeah.
Well, and I think having adult children understand we are not perfect. We're doing the best we can. But communicating and coordinating care with the doctor, with the Medicare agency, so that we are doing the right mechanics and aren't doing the right things. And it's okay if we don't know exactly what we're expected to do, but we're there to learn and we're there with open arms.
Sure.
And we'll always have a supervisor there, an RN, LVN, to oversee as well. So if this caregiver calls in sick, we'll be able to teach caregiver too if something happens.
That's right.
And so I think people are in such crisis and stress about their loved ones that they forget it's a teamwork. We're working behind the scenes more
we're
than
all on the
people.
same team here.
And that's where that breaking down of those silos is so important, right? The nurse doesn't need to be staying in her nursing lane and therapy in the therapy lane, obviously from a practice standpoint, but we need to be communicating across those channels with everyone who's involved in the case, including private duty, including the family members, so that we're all trying to achieve the same unified kind of set of goals.
Yeah.
Communication
and where you
so key.
Yeah, when you break down the communication, whenever there is a breakdown of communication, that's usually when things go bad, right? It goes bad clinically, it goes bad for the families. Their stress level is already heightened, and you just made it worse because we're not communicating with you. So we tend to overly communicate with our private duty people, our assisted living, our doctors, our family members. I get texts all the time from family members. We're just texting back and forth in the evening time because they're anxious, they're stressed, they're worried about mom, they're worried about dad, they're worried about their wife, and so if I can take 10 seconds to send them a quick text on advice or whatever, then it helps them to feel a lot more confident and trust with us as well.
Well, and also, working with hospice as well. I mean, I've had some caregivers call us, or they call the hospice, and the hospice says, you know what, I don't have anything to do with you, you're private duty, but that's not true. And I'll say, no, it is regulatory. We coordinate care. We work together. We need to know, the right hand needs to
Right.
know what the left hand is doing. And that's how we provide
right.
that quality
That's right.
care.
Yeah, they're missing out on what ultimately has to happen in this client's best interest. And it's going to be
I know.
collaboration with private duty or whoever else is the interested
With
parties.
any
Yeah.
vendor, if you
Yeah.
will, whether it's
I
private
know.
duty, hospice, home health,
Yeah.
it's continuity of care. If we all communicate, we're all on the same page, we know what's going on, and then the family feels more comfortable.
Yeah.
Everybody's happy.
So let's go back to group homes, Brian. And there are a lot in DFW. And, I've said it before, you guys are the best in DFW.
Thank
And
you.
shout
Another
out. Y'all
$20,
do a
right,
wonderful
right.
job. And I'm not just saying that to blow smoke.
Yeah.
Y'all do a great job. You've got a doctor, you've got an RN. You have the big picture. You work with the Medicare agencies. If you see a need, you will call Brian. And you know what? I think Mrs. Jones would benefit from some physical therapy or some speech therapy or whatever it is. And I love that. Like, you see the big picture. But I want to talk about with group homes, and I'm a huge fan of residential care homes that do
Yeah.
things the right way. In a perfect world, and I know you have the ratio of 4-1. Okay. In a perfect world, step out of your role as community liaison. What is a perfect ratio other than 1:1? We all know that's the best ratio.
Wow, what is a perfect ratio?
What is a
Well,
perfect
let me touch
ratio?
on something. You mentioned we have a doctor and we have the RN. We also have a director of life enrichment who, not to put the medical side down, but I think the director of life enrichment is almost as important as the medical side, because that's where the one-on-one activities come in. And she is with every resident on a daily basis. And that's so important.
Yeah.
That one-on-one engagement, because where one person may be able to play bingo, the other three aren't, and they still need the same interaction. So that's a real important component.
Yeah, and just people's needs, their spiritual needs,
We meet them where they are.
Right.
You meet them where they
Yeah.
are. To answer your question about ratio, it's so personal depending on what the care needs are for the prospect, for the resident, for the person. And some people are applicable for the larger facilities, like we talked about earlier with the happy hour in the movie theaters. That's home. That's where they should be. But if they need the care, we cater to very high acuity, high need residents.
Mhm.
If that's where you need to be, then be where you need to be.
Mhm.
Don't think, oh, we're not ready for that. She's still got some years left in her. We're going to, happy hour. That's not your focus.
Right.
The care is your focus.
Yeah.
Mhm.
So.
Well, I appreciate y'all have been so outstanding. I
it's
appreciate
fun.
it so much. If anybody wants to reach out to either of you, Brian, your Medicare, you are top in your field here in DFW.
Thank you.
And so how can they reach you personally?
They can follow me on LinkedIn. I'm on Facebook, and you can reach me on my cell phone number, 321-271-4052.
Okay. And Brian, how about you?
LinkedIn, Facebook, 214-649-9922. Manchester Care Homes and Cambridge Caregivers both have websites. You can
And we're always available. If someone has a question, one week I want to do a Q&A where people email questions that we can just answer.
That's great.
Because it is the what, who, where, what do I do? Anyway, if somebody has some questions on topics that we could help, and we are not the experts in everything,
but we'll find an expert.
we'll find
Right.
we'll find an expert. But just wanting the best for your client may not mean, or your loved one may not mean working with Brian or working with me. But we will help you find.
We have resources.
Yes.
Absolutely.
Yes.
Thank you for having us, and thanks for
Yeah.
plugging
Thank
our
you.
companies.
Yeah.
It's your turn. Why don't you talk about your pajama
Well, and
drive?
thank you so much
Yes.
for that. We are doing right now a Pajamas for Seniors Grandparents Day drive. With the isolation, our seniors are more isolated than ever, especially our low and no income seniors. And we are looking to sponsor 5 nursing homes in the DFW area. We're going to get pajamas for all the men and women in each community. Fall, not too hot, not flannel, but not too cold. Just something for the fall. Right now, most people that are in Medicaid nursing homes, the statistics are staggering. 70% have 0 friends, 0 family.
Oh, man.
zero visitors. The visitors they do have are from churches or community groups or Kiwanis clubs or school choirs. Those aren't happening. They're not going to send those. So they're more isolated than ever. We are losing our seniors in these communities. And so just giving a pair of pajamas, just making someone feel loved and special and warm and needed and of value.
And a good night's sleep.
And a good night's sleep without having your behind sticking out in a hospital gown. That means so much. We are taking donations. We're doing virtual drives. So you send us $20 and we will go and purchase the pajamas. You'll have lots of pictures that we can share. And I want to share one more thing. With these Medicaid nursing homes, those staff members are absolutely exhausted.
Yeah.
If it's a community, and I'm going to give a name, Brentwood, 1, 2, and 3, they have the highest number of Medicaid patients, homeless, COVID patients, because these patients are in the hospital or homeless, have nowhere to go, and they're sick. So Brentwood is going to take them, but nobody wants to take care of them. So you've got your activities directors giving baths. You've got your cooks giving baths, doing incontinent care. It's horrible. And people don't talk about this, and it's important to talk about. We're all fortunate that we work with the private pay client. I know, Brian, you're with Medicare, but even having those benefits, not everybody has been that fortunate. So really, you can make a difference. Pajamas for Seniors, give. We will get that. We take no salaries. We will get that to those people in need and just make their grandparents' day. It's September 13th. We're collecting through September 10th. So thank you so much.
Great.
Thank you, Jen. Yeah.
All right. And y'all have a good day. Have a blessed weekend. Stay safe and keep those masks.